It's a real pleasure to be part of such a fantastic lineup of speakers, and I very much hope that you've all been enjoying this series as much as I have. You might be a little confused that the title showing here is slightly different from that advertised in the programme, but in fact I'm going to be dealing with many of the same issues of infrastructure and development and questions about what infrastructure for off-the-grid living might look like. But the reasons for a shift to focus on infrastructure for health in particular will, I think, become clear very soon. But let me begin by asking, what is infrastructure? We don't often ask ourselves this question. Infrastructure is something that exists in the background. It's what enables our modern economies to work and our societies to function. We both fundamentally depend on infrastructure and simultaneously give it little thought. Indeed, we often only address the question of what exactly infrastructure is and what we expect from it when our infrastructures fail. Today, questions of infrastructure are nowhere more visible or more urgent than in West Africa, where the Ebola crisis, since its outbreak in December last year, has claimed over 4,000 lives. What is it that has enabled the Ebola virus to spread so virulently where previous outbreaks were quickly contained? The answer to this question that experts in the WHO, MSF, the World Bank and health ministries tell us is not culture or poverty or biology, or certainly not those things alone. The answer is infrastructure. In many of these countries, there is no access to running water for health workers to wash their hands. There aren't enough hospital beds. There aren't enough protective suits. In Guinea, there are reports that there aren't enough rubber gloves available. There are no established systems or protocols for dealing with an outbreak because it's never hit this part of Africa before, and there aren't enough human resources. Until recently, we thought that we in the West had these infrastructures, and it's the developing world that doesn't. Indeed, the presence or absence of basic infrastructures has been a really key way in which we've defined what international development is. Such assumptions are now being tested by the spread of the infection to nurses working with infected patients in the US and in Spain. It turns out that healthcare infrastructures in the US and Spain may in fact actually be weaker than those being created in Liberia, for example, by organisations like the MSF, which rely on plastic sheeting and other kinds of limited resources. And indeed, only yesterday, Barack Obama actually met with government officials specifically to address the preparedness of the US health infrastructure. It's also interesting to note that the World Bank had their annual meetings last week, and these meetings were dominated by two issues: Ebola and the $1 trillion annual infrastructure financing gap in developing countries. Where previously, if I mentioned infrastructure, you might think about water, energy, or transportation infrastructures, Ebola has now really put the question of infrastructures for health squarely on the international development agenda. So in light of the Ebola crisis, I've decided to deviate a little from what I originally planned and focus this talk on the question of what we might mean by health infrastructures, or what effective infrastructures for global health might actually look like. If this lecture series is about our changing worlds, there's no more important issue facing us today than that of Ebola and the inadequate response so far of the international community to it. This sudden concern about health infrastructure is highly revealing of what exactly we think infrastructure is and what we expect from it. So when reporters or government officials or WHO spokespersons describe the lack of health infrastructure in West Africa, they're often imagining infrastructure in a very particular way. We're told that there's a shortage of things: buildings, vehicles, equipment, technologies, and human resources, but also a shortage of connections between these things. So infrastructure is often imagined as a network and often a network of systematic connections that should extend across a national territory. It's imagined as something centrally planned and governed and controlled. And it's often imagined as the physical foundation for a service, what makes states like Sierra Leone considered fragile and in need of development intervention is precisely that they're unable to build the physical infrastructures upon which a basic service like health depends. Well, what is there to question about the way in which infrastructure is being imagined here? Indeed, if I was to ask each of you for an example of infrastructure, you'd probably give me something very similar. You might talk about dams or power grids or water systems or sewers or railroads. These are physical and technical systems that connect up different points on a map. They operate, if you like, as grids. Indeed, the grid has become a really powerful metaphor for thinking about infrastructure. The term derives from the networks of pylons and cables that emerged in the early 20th century to create regional systems of electricity supply. But other kinds of infrastructure are also modelled on the grid. The national health systems that were established in the UK and many other countries in the latter half of the 20th century, for example, were modelled on the idea of a network of fixed facilities and then roads that can take patients and medicines between them. And this way of thinking about infrastructure has close associations with the word's etymological roots. So this term infrastructure actually emerged at the end of the 19th century in France as military parlance to describe fixed installations and then that are connected up to form a system. Modern ideas about infrastructure have similarly been based on what I call a point-to-point or grid-based model. And this idea of infrastructure has really underpinned the infrastructure work that's defined 20th century international development efforts. The idea of development had its origins in the post-war reconstruction efforts in Europe and the US. Large-scale infrastructure was seen as an engine for industrialization and economic growth. With the establishment of international lending institutions like the World Bank, these ideas were simply transferred to what were known as less developed countries. Since its establishment in 1944, the World Bank has traditionally given loans to less developed countries to build infrastructure projects for transport, water, sanitation, or energy. And over the years since it was established, infrastructure has actually taken up about 30 to 50% of World Bank lending. But our ideas about infrastructure and our expectations of it in international development are changing. Development by the 1970s was no longer just about raising GDP. It was also about eliminating poverty, generating livelihoods, improving the quality of life. This didn't really lead to a rethink of what infrastructure is. It's still imagined to be a large-scale technical system. But what we expected from infrastructure had changed. Now, for example, improving electricity grids was about improving the quality of life and contribute rather than just contributing to growth. It was about supporting small businesses and entrepreneurship. The World Bank, in other words, had started taking a microeconomic rather than a macroeconomic perspective. By the early 2000s, this had changed again. The Millennium Development Goals had been established, and these goals were focused on eliminating hunger, disease, and child mortality. Indeed, health was now seen as the central means of alleviating poverty. Today, the World Bank infrastructure page actually starts with this statement. Infrastructure is critical to support the social progress and the achievements of the Millennium Development Goals. So what we expect from infrastructure has changed again. In some ways, you could say it's expanded. So our ideas about what international development is have changed, and with them our expectations about what infrastructure should do. But we've also seen a shift in ideas about who should provide that infrastructure. And the private sector is seen as really important here. So development economists have argued that we need private investment in infrastructure to stop poor states from getting into more debt. So governments have been advised by lending institutions like the World Bank to privatise public infrastructure, for example, by introducing user fees for water, or they've been advised to sell off public utilities to secure greater investment in them. This, it's thought, will make running those infrastructures both more efficient and more economically sustainable. And we can really see this thinking in the resurgence of infrastructure on the global development agenda, and also in the establishment over the last three years of multiple new public-private infrastructure funds. These have included, for example, the African Union's $11 billion programme for infrastructure development in Africa, the Made in Africa Foundation's Infrastructure Fund, which was launched at NASDAQ in September 2011, and US President Obama's $7 billion Power Africa programme, which was launched in June 2013. All of these funds have focused on raising private investment for infrastructure in Africa. So we have two central ways of thinking about infrastructure for development here. First, that infrastructure is about eliminating poverty, and secondly, that the private sector investment and public-private partnerships are the best way to build and manage such infrastructures. But alongside these ideas, we're also seeing a growing interest in the idea that infrastructure can be designed for off-the-grid living. So where previously being off-the-grid, in the sense of being beyond the reach of centralised, planned, top-down public infrastructure, was seen as a problem, it's increasingly being seen as an opportunity. Indeed, grid-like infrastructures might actually be problematic. They're expensive, they require huge investment, they're security risks and easy targets for terrorists, they're unsustainable and often fossil fuel intensive. So increasingly, governments, aid agencies and academics are all looking to places that are off the grid for infrastructure solutions that may be more robust and resilient, and that may indeed represent the future of infrastructure for the developed world too.
60 years ago, less than 300,000 people lived here, and everyone used to say Lagos was gorgeous. Now it's more like 16 million, and most people would agree it's suffering from a few growing pains. But despite its reputation for corruption and poverty, Lagos is not all like that, you know. These people will show you what ghetto life is really like.
You have oil in your village, you come to my area, you have oil.
They've learned to be smart, resourceful, they're hustlers. Because here, nothing is wasted, and everything is an opportunity.
So this was the BBC's 2010 documentary, Welcome to Lagos. Can I just ask, did anyone here see that documentary? It's really fantastic, gripping piece of documentary work, so I really recommend it. And part of the point of this documentary was that life in places of poverty and without access to the kinds of modern infrastructures that we take for granted aren't all about doom and gloom. In fact, we can actually look to the way in which people live in these places, their creativity and their innovation, with the very few resources that they have for inspiration. Without a large-scale waste management system, for example, small-scale entrepreneurs have started collecting rubbish and then selling it on to companies that want those materials. The point is that the local response to this lack of infrastructure actually creates income generation opportunities for the local people. And documentaries like this one really reflect a growing sense in the development industry that maybe people don't need large-scale infrastructure. In fact, maybe the organic bottom-up infrastructures that emerge in the gaps where those traditional infrastructures don't reach are actually better, more resilient than grids. In the wake of this new interest, off-grid locations are also becoming laboratories for designers, big businesses and social entrepreneurs to design and develop new kinds of infrastructure. And let me give you just a few examples of what these infrastructures look like and the ideas that underpin them. So I've described how one really powerful idea in infrastructure and development right now is that infrastructure can be an opportunity for new partnerships with private investors. An influential figure in management and business, C.K. Prahalad, is taking this further. Prahalad saw people who are living beyond the reach of large-scale public infrastructure as a latent market. These people are very poor, and individually they have very little money. But as a mass market, they're a real opportunity for business. Now, we might not be able to get the kind of big private investment needed to build, say, for example, a large municipal waterworks in an Indian slum. But what you might be able to do is develop small-scale infrastructure products that can be sold to the poor at affordable prices. One example of this is Hindustan Unilever's water filter, Purit. This water filter is designed to enable households. It's quite small, about this large, and it just sits on the counter in your kitchens. And it's designed to purify unclean water from the mains at source. It's also designed to be affordable. It costs about £12. Now, this is still a lot of money for the people Prahalad is talking about, people who live off less than $2 a day. But Prahalad's vision is that such products will be sold and marketed through microcredit schemes. So in a sense, this commodity, a water filter, is made to substitute for a municipal water purification system. People can buy their infrastructure. They then live healthier lives, they have higher quality lives, they're more productive, they contribute more to the economy, and businesses make money. For Prahalad, this is a win-win situation. Businesses make money, the poor receive basic services. And it also generates livelihoods as poor people sell those products to one another through their social networks. So here we have infrastructure as a product to be consumed rather than a service to be provided. And we also have infrastructure as something that's targeted at individuals and households rather than communities or nations. The households that buy a water filter have clean water. The households that don't buy a water filter don't have clean water. Infrastructure becomes something you choose rather than something that you simply have by default as a citizen. Now, the Purit water filter is an example of a small-scale technology that has been designed to replace a large-scale system. And this is another characteristic of infrastructures that are designed for locations that are off-grid. Infrastructures are being built into boxes. So to talk about another example, here's the rapid diagnostic test for malaria. This is another example of a technology that is being designed for places where infrastructures don't reach. Malaria in Papua New Guinea is a huge problem, and up until recently, the only drug available to treat it in public health facilities was chloroquine. There weren't any laboratory infrastructures, so health workers in those health facilities weren't able to test and diagnose patients for malaria. And so the WHO recommendation was that you simply treat all patients presenting with a fever with chloroquine for malaria. Now, obviously, this is really problematic and it has spread to widespread resistance, but also it was recognised by the WHO that this is all that people could do. To save lives, this was the correct protocol to take. By the early 2000s, however, a new kind of drug had been developed. This was artemisinin combined therapy. It's far more effective, but it's also more expensive. The WHO is worried about the cost for ministries of health if they treat everybody. If they treat everyone, for example, with a fever rather than just the people who actually have malaria. The assumption being that huge numbers of people have been treated with malaria up until now who actually probably have other conditions. They're also worried about resistance if we simply treat everyone who has a fever with artemisinin combined therapy. But there's still no laboratory infrastructure for health workers in rural areas to diagnose malaria and establish who should get the drug and who shouldn't. We need microscopes and power in every health centre, or you need reliable transportation systems to be able to get samples to urban centres more quickly. In Papua New Guinea, both of these are impossible. There are very few roads. There's no power network beyond urban centres. And the solution to this has been the rapid diagnostic test. So what is it? Well, it's a simple cassette. You prick a finger with a lancet, you drip the blood into the cassette, you wait 15 minutes, and then a line appears in a small window, or it doesn't appear. You don't need a laboratory, you don't need a network of laboratory technicians, You just need the box. The RDT cassette is accompanied by a small capillary tube, a bottle of buffer, an alcohol swab, a blood lancet, and an instruction manual. The only external input that the test requires is a drop of blood from the fingertip and around 1 hour's training for the person administering the test. The entire laboratory infrastructure is, if you like, simply built into the box. Now, whether technologies are actually able to operate as infrastructural systems is a question that we're going to be returning to in a moment. So another kind of infrastructure that is getting a lot of attention in locations that are off-grid is communication technology. People working in international development right now are really interested, for example, in the ways in which the mobile phone or the internet might provide alternatives to traditional health infrastructures. An excellent example of how the mobile phone networks are being promoted as solutions to the lack of other kinds of infrastructural networks is the SMS for Life project, which is funded as a public-private partnership and led by the pharmaceutical company Novartis.
Today in Tanzania, it is estimated that 220 people died of malaria. The same amount died yesterday, and the same amount will die tomorrow.
If you have malaria, it's a treatable disease. You treat with medicines. If medicines are not there, you can die.
Unfortunately, stockouts of certain medicines at the health facility level in many sub-Saharan African countries have been an ongoing and persistent problem for many years. To combat stockouts, Novartis led the creation of a public-private partnership called SMS for Life, which brings weekly visibility to the stock levels of anti-malarials in local health facilities.
So the idea is that on a weekly basis, we would send out an SMS request message to all of the health facilities, requesting them to enter the current stock of antimalarials. All the data is then collected in a central system, and all the data then becomes available via the internet or BlackBerry mobile phones for district medical officers or other users to see.
So Novartis, they produce a leading anti-malarial Coartem. And Novartis, on a trip to Tanzania, realised that one of the major obstacles that's preventing the eradication of malaria in developing countries is the lack of availability of Coartem in rural health centres. This is a problem that's being framed here as last mile distribution. Rural health centres are a long way from urban centres. There are very few facilities for a very large number of villages. And systems of stock taking and supply still rely on these old paper-based systems that take a long time. So it simply takes too long in these contexts for a health facility to be able to respond, for example, to a sudden upsurge in demand in the village. And this leads to frequent stockouts. So Novartis set up a public-private partnership between IBM, Google, Vodafone, and the Tanzanian Ministry of Health to create an SMS system for health workers to record their Coartem stock and relay that information direct to district health managers, the idea being that these district health managers can then respond very rapidly and immediately by sending Coartem to the locations where it's needed. Now, in a sense, this isn't really about being off the grid, but about embracing new kinds of grids. The idea is that the developing world can leapfrog old, clunky, sedentary infrastructures and leap straight into the smooth, virtual infrastructures of the 21st century. Indeed, being off the grid now refers as much to being off the communication network as to being off the electricity network. Now, one way of thinking about this is that we haven't really gone beyond a point-to-point infrastructure. Instead, what we've done really is just add a lot more points. So points aren't big infrastructural edifices like hospitals. They're now individual people with handsets, which are connected to mobile phone towers and mobile signals, joining up to create ever more connections. This is still a grid, but it's clearly a vastly more complex one. Now, traditional ideas about infrastructure have often focused on physical infrastructures, but policymakers are increasingly interested today in the ways in which standards, protocols, and systems of classification might actually be incredibly powerful, an incredibly powerful form of infrastructure in off-the-grid locations.
Well, he was stable, and given a stab wound that didn't look too bad, they decided to go through with imaging. And then 5 minutes later, he crashed right in front of their eyes. He lost his blood pressure and started to die on them. They then switched gears, rushed him back downstairs, and it was all they could do to save him. He was in the hospital for over a week from a stab wound that turned out to have gone through his belly. He was over 200 pounds, almost a foot and a half through him into his aorta and lying in the back of his body. And a surgeon who was there had been a surgeon in Vietnam, and he said, I hadn't seen a wound like this since Vietnam. And it turned out he was right. They learned afterwards they forgot to ask one question. What did the weapon look like? It turned out he was at a Halloween party where the other guy was dressed as a soldier and stabbed him with a bayonet. And if they had been able to not miss that one question, what does the weapon look like, they would have figured out this was a much more dangerous wound.
So this is Atul Gawande, surgeon in Boston and lecturer at Harvard, who's really concerned about the mistakes that are being made in modern surgery. And he says these mistakes are being made because surgery is simply so complex. There are so many things that you have to remember to do, and it's just impossible for any individual to keep all of those things in their head at once. But then he said, well, okay, but flying aeroplanes is complex too, and putting up skyscrapers is complex too. But aeroplanes rarely crash and skyscrapers don't usually fall down. And the reason he found out was because they have checklists. The checklist enables us to make sure that the most important things have been done. And this gave Gawande the idea that amidst all of this complexity, it would be possible to find a basic, simple algorithm for reducing risk in modern surgery. So with the WHO, he then decided to create an international checklist for safe surgery. And what's really important about Gawande's checklist was that it was designed for use anywhere. He's often on these chat shows in the US talking about the American healthcare system, but Gawande was someone who was actually just as concerned to make sure that these checklists would work in lower income countries as well. And the checklist for modern surgery was actually tested in 100 hospitals around the world. So the idea is that even in places where we don't have very elaborate infrastructure, lives can still be saved through really basic practices. In fact, physical infrastructure might actually be less important than standardized protocols for what people do. Indeed, the checklist, according to Gawande, might actually be the most important and fundamental infrastructure that a health system could have. So I've given you a few examples of the kinds of thinking around off-grid infrastructures that is going on right now in the international development and business worlds. What does anthropology have to offer in relationship to these? Well, anthropologists are interested in everyday practices. What actually happens? How, for example, do infrastructures designed for off-the-grid living actually work? And what do they do to people's lives? Anthropologists are interested in why people do what they do. So whereas psychologists are interested in explaining why people do what they do by looking into the dynamics of the individual mind, or economists explain why people do things in terms of economic rational self-interest, anthropologists are interested in understanding the ways in which our relationships and the values that we share shape the things that we do. Now, often this helps us to explain why people might do things that actually look quite strange. If we understand these things in terms of the social and cultural context in which people live, then they actually can start to make quite a lot of sense. So what anthropologists are often most interested in is our basic hidden assumptions about how things work and what is important. By looking at the ways in which those hidden assumptions might be specific to a particular collection of people, we're also able to show that what they take for granted as natural or given might actually be historical and cultural. So how can we use this approach the kinds of approaches that anthropologists take to problems to think about infrastructure, and specifically to think about off-grid infrastructure. Well, let's think about the rapid diagnostic test again for a moment. Here we can see that key assumptions are being made about its simplicity. It looks simple, we're told it's simple, but by examining the way it's actually used in practice, we can reveal that it's really very complex. So the one external factor that the organisations who are designing, promoting and distributing rapid diagnostic tests acknowledge can't be put into the box is the health worker. But we're told the RDT test is so simple to use, and the way you use it is so self-evident that it should only really require 1 hour of training. Well, my initial research in Papua New Guinea has shown that the role of the health worker is far, far more important than this. So I'll just tell you a little bit about the story of the rollout of RDTs in Papua New Guinea. The Papua New Guinean government originally procured one particular type of RDT. And one of the things is that actually, as the market for RDTs has proliferated with the rollout of this new medication, so the number of different kinds of tests on the market has proliferated as well. So the Papua New Guinean government procured a type D RDT. And on this RDT, if the first line in the window appeared, this told the health worker that the patient had falciparum malaria. If the second line in the window appeared, it showed that the patient had some form of non-falciparum malaria. And these two different diagnoses require different treatment, so it's very important to read the test correctly. So to make sure that this happened, the Global Fund gave money to the Papua New Guinean government to roll out a national training program for health workers that showed them how to use this specific RDT, and this is some of the materials that they used in that training. However, a little later on, after these RDTs had already been procured, the Global Fund discovered there'd actually been some inconsistencies in the tender process, and the government was told they actually had to cancel that tender and procure a different rapid diagnostic test, which was all well and good. It delayed the whole process by about 9 months. When the new one finally arrived, it turned out that the lines were the other way round. Falciparum malaria, the line for falciparum malaria was now where the line for non-falciparum malaria used to be. So they told the health workers to follow a fixed set of rules. It's simple, but these rules no longer applied to the new test. Ultimately, the Global Fund had to accept that the Papua New Guinean government simply had to go back to their first tender. This, of course, delayed the process by another 6 months. So these tests aren't as simple as they seem. Minute differences in their design really matter. And the health worker matters. There are other ways in which the health worker matters too. For example, these are people who've actually been trained to treat for malaria presumptively with anybody who presents with a fever. For years, they've been told to do this. It's unclear to me that these health workers are going to actually follow this protocol. So when they get a test that says a negative result, that a patient doesn't have malaria, the options for that health worker are very limited. There are very few other treatments that they can give, probably only antibiotics. There are no other diagnostic tests available in these rural health facilities, only ones for malaria. So with no other options for diagnosis or treatment, it seems to me it would be quite kind of rational and reasonable for health workers to actually continue to treat patients presumptively, even if the test is negative. Another issue that hasn't been given enough attention by designers, temperature. Now, like many medical devices and pharmaceuticals, the rapid diagnostic test can't be exposed to temperatures over 30 degrees or to direct sunlight. This is the area of Papua New Guinea where I work, and the health centre that I work in, I haven't got a little infrared thing, but the health worker I work in is where, health centre I work in is where you can see that small house down in the bottom right-hand side of the screen. But the highway stops a good sort of half the screen up, and top of that, about 5 hours walk from the health centre. So the RDTs are dropped off in places like this, a small market on the side of the highway. And they might be left there for hours, sometimes days. They're certainly not kept under 30 degrees. So we might not need a laboratory infrastructure, but we clearly need other kinds of grid-like infrastructures. What I realised the distribution system for RDTs really needed was actually a cool chain. So what are the hidden assumptions here? Well, perhaps it's an inability to understand what it really means to have unreliable grid-like infrastructures. So that this isn't only about a lack of laboratory infrastructure, but it's about a lack of transportation or refrigeration as well. And perhaps the assumption is that it's possible to design universal technologies, technologies that are context independent, that will work anywhere and produce the same results. So now this rapid diagnostic test is at the highway, but how is it going to get to the health centre? Well, the only way it's going to get to the health centre is if people carry it. It has to be carried. And this is really hard work. I've seen women carry rapid diagnostic tests in large net bags on their foreheads that could weigh up to about 50 kilos. People are willing to do this, but they're willing to do it as long as they feel like the health centre is working for them. If relationships with the health worker break down, for example, if he has an affair with a local woman, if he doesn't turn up to work on time, if someone dies in his care, then they're going to stop carrying those boxes, and I've seen that happen on several occasions. So here we can see how people become infrastructure. They actually substitute for the road and the cars by carrying these loads. But this kind of infrastructure only works as part of a relationship between community and health workers. So one way that the Global Fund is dealing with this issue is actually to pay people. They're trying to bypass the unpredictability of that social relationship by transforming it into a monetary transaction, because they think that monetary transactions are more reliable. The problem is that they're only actually paying people to carry the rapid diagnostic tests. They're not paying them to carry other normal medicines like antibiotics. The government is in charge of distributing those medicines, and the Global Fund is only taking responsibility for malaria. So then the people carrying this stuff start questioning, well, why should we carry anything without being paid? And they stop carrying these normal medicines like antibiotics, but the government doesn't have enough money to pay them. Anthropologists can also look at how far new kinds of infrastructures reach. I often think there's a kind of fantasy around new communication technology. We're given the impression that all of Africa is within reach of a mobile phone signal. New virtual grids are imagined to have even greater reach, more comprehensive coverage than traditional physical infrastructures. But through on-the-ground ethnographic research, anthropologists can examine how people actually access and use these new technologies. So this photograph is from the Middle Ramu. This is the poorest district in Madang province in Papua New Guinea, where I work. There's very little infrastructure here. When Papua New Guinea got independence in 1975, they got independence from Australia. They were Australia's only colony. Australia hadn't built any roads in this district at all. In 2011, when I visited this area, there were still no roads. This health centre depended on a radio for communication with the administrative centre. And this was a radio which was actually solar powered and had been installed by AusAid in the early 1990s. But this radio system is deteriorating, and some of the health facilities that I visited, their radios are broken and not working. In fact, the provincial headquarters for health in Madang told me that some health centres hadn't actually been in contact with them for 2 years. Now, AusAid is reluctant to invest in these kinds of radio systems anymore. And the reason is because they see mobile health as the future. But places like this have very low population density, and the people who live there have almost no money. So there's no incentive for mobile phone companies to invest in the infrastructure of mobile phone masts that would be needed to create a mobile phones network here. So this is a place that is both beyond the reach of state-provided infrastructural grids, but there's also no incentive for private investment in off-grid infrastructures. Now, Anthropologists can also ask questions about protocols. So when a man presented himself to Dallas Hospital in Texas with a fever and abdominal pain with a recent travel history to Liberia, the nurse on duty used a Centre for Disease Control Ebola checklist to evaluate him. This was a checklist that Atul Gawande actually helped to develop. And the nurse then passed the patient on to a doctor, and that doctor should have seen the checklist, or he should have been informed of that man's travel history. But for some reason, this crucial piece of information wasn't communicated. The checklist didn't work. This man returned to hospital several days later when he was severely ill, and as you all know, he was diagnosed with Ebola and later died.
Because at least in the case in Dallas, in the hospital, it went to something you've also written about, the checklist idea. The patient comes in, there was not enough awareness to see that there was Ebola, he was released, potential further trouble from that. What do you take from that, from what you've seen so far?
Well, there are a couple things. Number one is basic public health and infection control measures will stop Ebola in its tracks. We know what needs to be done. Executing on it means that we take seriously the idea that we pass infections in hospitals. Mm-hmm. 2 million people pick up infections in hospitals per year. I wrote about it, as you say, in my last book, the Checklist Manifesto. And that if we use the basic checklist to execute on what we know how to do and ensure everybody on our teams does it, we now know what's required to identify a person who might be at risk of Ebola. We know how to isolate them. We know how to protect ourselves and the patients and everybody else around them.
We know, but it doesn't happen.
Well, so what's happened in the last week may be the best thing that's ever happened for all patients across the country. We are not going to have an Ebola outbreak running wild in America because it is so straightforward to shut it down when we have a functioning healthcare system. But now people are downloading the checklists. They're learning how to use them. They're learning that, the way you take the gowns off and put the gowns on make a big difference in whether you've passed an infection to somebody else, and how you wash your hands. All these things matter.
But the question for anthropologists is, well, why was that checklist used in the way that it was? A key concept for anthropologists is context. What happens to objects like checklists when they're used in particular contexts? Why did the checklist not lead to vital information being passed between a nurse and a doctor? Well, the point for me is that there was nothing in this checklist itself that would make someone follow the checklist. This simply depends on the context in which it's used. Indeed, if the health infrastructure of Médecins Sans Frontières is actually more effective at containing infection than the US healthcare system, might that have something to do with the different ways in which the protocols are being perceived by doctors in these two places? Anthropologists might ask questions, for example, like the impact that hierarchy between doctors and nurses has on those relationships, or are there ideas of expertise and values of autonomy that make doctors resist the use of checklists? This isn't to say that checklists aren't brilliant, really powerful devices. Rather, it's to say that checklists do not exist independently of the relationships in which they're designed, built, and used. In order to work, checklists have to be adaptable to the relationships in which they find themselves. Indeed, Gawande clearly recognises this, because at the bottom of every checklist he's ever helped to develop is this statement: the checklist is not intended to be comprehensive. Additions and modifications to fit local practice are encouraged. And this really raises the question for me of how you might design a flexible checklist. So the checklist is a powerful technology, but on its own, it's not an infrastructure. It becomes an infrastructure when we look at the relationships that mobilize it. Similarly, the rapid diagnostic test is not a diagnostic infrastructure. It becomes a diagnostic infrastructure through its relationship with roads, with the people who'll carry it, with the health workers who'll use it, and the drug protocols that it's meant to be used alongside. Now, some of these relationships involve people. Some of these relationships involve other material things, such as roads, or environmental factors, such as temperature. So anthropology offers really 3 important ways of thinking about infrastructure. First of all, infrastructure is a relationship. We cannot just think about infrastructure as a physical thing, or just as connections between points on a grid. We also need to think about the relationships with people that are being built into it and that it depends on. Secondly, if off-the-grid infrastructures are increasingly meant to be driven by inclusive markets, do these markets also have limits? Places like the Middle Ramu district in Papua New Guinea neither have public sector grids, nor is there any incentive for private sector investment. Inclusive markets might actually generate new pockets of exclusion. 3, infrastructures that are built for use in locations off the grid often continue to rely on relationships with more grid-like infrastructures. RDTs, for example, depend on a transportation system. Even mobile phones depend on a coordinated network of mobile phone masts. One of the reasons why the health system infrastructure in Guinea, Sierra Leone, and Liberia are so weak may in fact be precisely because global health institutions have not thought enough about the relationships that make up effective infrastructures for health. Instead, infrastructures like the rapid diagnostic test or the protocol have been expected to do too much work. Vertical programs focused on these technological solutions have left health systems to deteriorate. One of the most striking factors about the Ebola epidemic, I think, is actually the incredible simplicity of the technologies involved. What you need is basic nursing care, intravenous fluids, blood products, rehydration salts. And infection control relies on a laborious but fairly simple set of protocols. So the question of infrastructure here is the question of why these basic elements are not in the places they should be, or why they're not being put into practice in the way that we expect. And this is not only a question about things or even connections between things, it's a question about relationships. And some experts on Ebola are starting to recognise precisely this. This, for example, is what is happening with the rethinking of containment strategies in West Africa. So for the first few months, the containment policy in West Africa depended on the old school model that when people are sick, they should be taken to hospitals and cared for there. But there's no ambulance service or no reliable ambulance service in many of these countries, so sick people actually depend on other people to take them to hospital. And this has been identified as a really important site of transmission. It's often when people see their neighbours or even strangers in the street who are sick and are actually helping to sometimes physically carry them to hospital, that transmission is occurring. And this is because it's only when someone actually gets really sick that Ebola becomes infectious, because it's only caught from bodily fluids. So it's actually precisely at that moment at which people are trying to get to hospital that they're most likely to be able to infect somebody else. So here again, we can see how assumptions were made about infrastructure. Because there were hospitals, it was assumed that they were the best place for people to go. But actually, hospitals don't work on their own. Hospitals, just like RDTs, are not infrastructures in a box. They rely on all kinds of other infrastructure, including people who carry other people. Second, Ebola kills the most vulnerable. The most vulnerable people are often in hospitals. So when a hospital gets Ebola and it starts affecting people who actually went to that hospital with other conditions, more people are going to die. So experts like Paul Farmer, the anthropologist, infectious disease specialist, and founder of the international charity Partners in Health, are now advising medical bodies to actually move the point of infection control closer to the point of care, that is, to the home and the community. We need to focus the resources on the women who care for their families and the community health workers who are their first point of call. And we need these people to have the right material provisions, gloves, suits, or rehydration salts, to both care and prevent transmission simultaneously. In other words, these people and their homes and the relationships in which they're embedded in their communities are actually part of the infrastructure. So to conclude, I suggest that the question isn't, do we need our infrastructures to come in grids or not? The question we should be asking is what kinds of relationships between people, technologies, and the environment make any infrastructure effective. So I started my talk by saying that when infrastructures fail, we become aware of how we expected them to work, what we wanted them to do. So what has been revealed in the failure of the health infrastructures in West Africa and now in the US? Well, it's not simply that West African countries need better infrastructural grids, more top-down, centralized, physical, large-scale infrastructures, roads, hospitals, beds. Nor is it that we simply need to develop more off-grid infrastructures like rapid diagnostic tests for Ebola. If we can learn anything from this disaster, it's that physical infrastructures do not work alone. In order to be resilient, our infrastructures must have resilient relationships with people, with technologies, with knowledge systems, and with the physical environment built into them. We need to start thinking about infrastructure as relationships. Thank you. So I was asked about the military being sent into Sierra Leone to try and help control the Ebola outbreak, which is a really interesting question, partly because a lot of the ideas about off-grid infrastructures for health actually come from the military. So the idea of the field hospital, a hospital that can just be sent out anywhere and could just be set up in a few hours, can effectively treat people. A lot of the kinds of technologies that actually are used in emergency medicine now come from military medical research. But I think what you're getting at is maybe actually there's more than that technology to the military, and that when the military go into a place like Sierra Leone, they actually might be having effects which are not just the effects of the physical technologies they're using, but also maybe their very presence as military personnel in a highly stressful situation. And I think that we need to be careful also in not just immediately jumping to conclusions that it's wrong for the military to be involved in something like this. There are a lot of very highly skilled medical personnel who actually have a lot of skills to offer in these kinds of situations. And those technologies are often life-saving ones. But I think what I'm asking for is an attention to that broader context in which the military are going to be working. So rather than just thinking about them going in, offering a set of kind of autonomous floating technologies and skills, actually think about what are these people wearing, what kinds of relationships do they have to the people they're treating or the other local health workers that they're going to be working with, what do they wear when they do this? Is there a way in which actually we could involve the military but prevent kind of too much securitization of health in these situations? And these are the kinds of questions that anthropologists would ask people like the US government or the WHO to think about.
My question is from the viewpoint of an engineer, because some of the things that I've noticed is that you're referring to anthropologists, but if you go back, 20, 30 years when particularly the UK development policy was to send the UK culture to these countries. And one of the things that engineers came up with was systems of looking at cultures and trying to determine what is the cultural difference between one country and the UK. So they came up with this transactional process of moving from one country to another, but understanding that there was a relationship between those two countries in how they operated. Do you think now that in terms of globalization, we need to start creating these catalogues, or I was going to use that word in terms of a metadata, in terms of converting from one country's relationship to another, so that we don't get into these simple mistakes, as you've called it, because I think that is one of the things that we're doing. We're assuming that we can readily take one product from one country to another and it to be working, and you're finding that it's actually killing people.
So one of the things anthropologists have become really interested in is actually the way in which relationships between people, technologies, what, for example, roads mean to someone in Papua New Guinea, what the dynamics of a relationship between the state and citizens might be in these countries is constantly changing. So I think that the solution certainly is to have more knowledge exchange between academic researchers and these policymakers, and also to have better interdisciplinary links probably between engineers and anthropologists. I'm not convinced the solution is a database.
You didn't mention the word education, as far as I remember, but obviously, I mean, a lot of these technologies, I think there is an assumption very often that the level of education and general knowledge that, you know, we can't even understand unless you've worked in a place like Sierra Leone or wherever. Basic things like transmission of viruses, you know, we take for granted here. You know, we know about transmission of infections fairly well from early on, but they don't there. They think could be something quite different. It could in fact be a big sort of USA plot, you know, and all the rest.
Okay, thank you. So I think there are also a few issues here. One is that often culture is presented in global health as something that people have to be educated out of, that maybe people have superstitious ideas about how you care for people, or stigma attached to people who get sick, and we need to educate people out of this. Recent research in medical anthropology has shown that actually culture is not the key obstacle to people accessing healthcare. The key obstacle is infrastructure. And actually people are often trying to seek biomedical care, and they're prevented from doing so because there's no road, because they have no money to get transport, because there are no medications in the hospital. So I think we need to always be wary when we think about relationships between education and culture. But clearly, there are challenges here of education that actually a lot of the things we're asking people to do and understand are coming from a perspective of biomedical science, which people haven't necessarily been exposed to before. And that is just a practical problem that does need to be acknowledged. On the other hand, what also needs to be acknowledged is that people anywhere have experience, and they'll have their own ways of knowing and dealing with disease and with a lack of infrastructure. And so education has to be seen as a two-way process, that there is a lot to be learnt from the ways in which people cope in places without resources and infrastructure.
One of the main issues that many have with the overarching development policies is a concept they call ecological footprints. The issue of how many, I don't know specifically, but it takes the consumption of one individual, and they see how many Earths you'd have to sustain it. How big of an issue is this in development policy and trying to make a sustainable development?
This is a question that I simply can't answer, I'm afraid. I'm not an expert on the ecological footprint. What I would say, however, is that not enough attention has been paid to the energy footprint of healthcare systems. So one of the things I'm seeing in Papua New Guinea is that getting medications out to places like the Middle Ramu depends on taking boats down a very long river. It's now becoming almost impossible for health centres to pay for the fuel costs involved in getting those boats down that river with their medicines. And so what we're looking at is actually a very fragile health system, because we have health systems that are dependent on fuel. We have health systems that need power. One of the key issues with Ebola is like, how do you actually put an intravenous line in when you don't have any light, when you don't have power to be able to see where that should be going? And what I'd really, really like to see in the future is someone, a statistician, hopefully, not myself, to actually do some research on what is the energy footprint of health systems in fragile states.
My research is kind of looking at a different infrastructure in a box, and that's solar lighting. I was really interested what you mentioned about these two malaria test manufacturers and the fact they had a different way of signaling the different types of malaria. So I was wondering if you could talk, because that's something I'm looking at, is specifically at the waste of some of these infrastructures in a box. You also mentioned the entrepreneurs in Lagos. So I was wondering if you could expand a bit on the role of the anthropologist with regards to these manufacturers of these technologies, and perhaps how we can improve those relationships so that perhaps those 6 or 9 months that you saw in Papua New Guinea don't occur, and if you have to switch to a different technology provider that maybe they're more compatible. Does that make sense?
Yeah, absolutely. I mean, I'd love to hear more about your research on solar, because I think there are a lot of crossovers there. I suppose one of the points is that I was trying to make was that these kind of assumptions of simplicity are being built into these things, so that there's a kind of technological determinism often going on here. And I think the role of the anthropologist is either to work with the designers, but also the policymakers and the people who are making decisions about which tests to procure or how to organise a national training rollout, to actually sort of, get down to the real micro details of what is involved there and how a history of a health system matters as well. You're asking me to elaborate. And can you tell me something about solar entrepreneurs and what I should be looking at?
So one example I've come across is there's one product that is in the market that has what you might refer to as a kind of proprietary screws. Basically, it's you can't dismantle this product as your entrepreneurs in Lagos would do unless you have the specific screwdriver that company uses. So that is a barrier to creating that kind of secondary market of refurbishment or recycling. So that would be one example of where these manufacturers aren't talking to each other about what could happen with their technology once it's in these off-grid areas.
I think one of the really interesting things about the area of health when we're looking at these kinds of infrastructures in the box is often these technologies aren't actually being bought by individual consumers. So these RDTs are being bought by the global fund. And I think there's there's a big difference there as well. So often we assume that these new kinds of technologies are all about entrepreneurship, and often they're being kind of marketed that way and sold that way. But actually often the people that these technologies are being marketed to are actually states or governments or MSF or the WHO. And they're a really crucial kind of intermediary there. And I suppose those bodies aren't really that concerned with those kinds of questions about reuse. I mean, with an RDT, you're not really looking at fixing an RDT or scrambling around with it. And that's sort of, you get into an interesting comparison with different kinds of technologies there. But certainly, once you actually kind of break down what that commodity chain is and who's really buying these things and how that might be a different person from the person using these things, then you get into a space where anthropologists can start intervening and say, well, actually, are you thinking about your users?
I'm sure some of you may want to come and have a one-to-one conversation with Alice, and I want to make sure there's time for that, whilst at the same time giving all of you an opportunity to ask questions. So can I ask you once again to thank Alice on our behalf for a fantastic lecture and some really great answers to questions. She's far too modest to talk about her book herself, but her book is here, and she also has some discount vouchers for it if anybody would like to come and talk about those. But thank you very, very much, Alice, and I'd like you to join with me in thanking you.